Hello everyone, my name is Amira and today I will be discussing chronic obstruction pulmonary disease, also known as COPD. Did you know that 1 in 20 Australians above the age of 45 years of age will develop COPD? And COPD was the fifth leading cause of death in Australia. So what is COPD? COPD is a condition where the airways found in our lungs, which are supposed to function automatically without effort, are now narrowed due to the obstruction present within the bronchioles and cause the lung to ineffectively function, to expand and contract, thus decreasing the volume of air to enter the lungs and minimize gas exchange to occur in the alveolus within the capillaries and are unable to distribute oxygen to other organs in the body efficiently. There are two types of COPD. One, chronic bronchitis and emphysema. Chronic bronchitis is a condition where the buildup of mucus obstructs the airway and constricts the diameter of the bronchioles, preventing the efficiency of airflow between the alveolus and the bronchiole. In emphysema, obstruction occurs due to the collapsing of the alveolus, losing its function to expand and recoil back into shape, disabling gas exchange. What exactly causes COPD? Most patients who have presented with COPD have had any exposure to pollutants that induces an inflammatory response that damage and obstruct the airways. The main risk factor of COPD is smoking, and most patients have had a long history of smoking in the past. Non-smokers that have been long-term exposed to partners or colleagues that smoke are also at risk of developing COPD. Living in urban areas also puts the population at greater risk due to the exposure of high concentration of air pollutants such as toxic fumes, dust, and silica present in the air. A genetic disorder of alpha-1 antitrypsin deficiency is also one of the causes of patients developing COPD. Moving on to our case study, Mrs. Marjorie McDonald, a 74-year-old female that was admitted to the emergency department with dyspnea. 5 years ago, she has been diagnosed with COPD, and for the last 7 days, she has been experiencing acute exacerbations with increased shortness of breath, productive cough, and fever. Going from her A to G assessment regarding her airway, she has been experiencing dyspnea, shortness of breath, and productive cough with yellow phlegm. Breathing, she has a respiratory rate of 32 breaths per minute, which is tachypnic, oxygen saturation of 86%, of an indication of hypoxemia, and wheezing was identified during auscultation. Concerning circulation, cyanosis was present, showing a bluish tinge to the lips and mucous membranes, and her heart rate of 132 beats per minute. Mrs. McDonald has not been able to perform her daily task, and her exposure to having a fever for the past 7 days is indicative that she has the possibility of infection. The chest X-ray result has shown hyperinflated lung fields and patchy consolidation. So throughout this presentation, I will be discussing the pathogenesis of COPD that leads to the acute exacerbations that Mrs. McDonald is experiencing. These exacerbations include tachypnea, tachycardia, cyanosis, hypoxemia, dyspnea, and wheezing, and the hyperinflated lungs. It has been explained by Kraft 2019, the most common cause of COPD is cigarette smoking and exposure to urban air pollutants. Due to these pollutants being inhaled and are present within the bronchioles, it triggers the body to produce an inflammatory response to remove these foreign bodies by producing mucus and undergo phagocytosis. Our bronchioles are made up of smooth muscles, accompanied by mucosal and submucosal glands and goblet cells that are responsible to humidify and moisten the airways and also trap any pathogens that enter the respiratory system. The exposure of these irritants cause hypertrophy and hyperplasia to these cells, the submucosal glands and goblet cells, stimulating an increase in sputum production. The effect of inhaling these irritants also cause ciliary dysfunction within the airways that shorten the cilia and reducing its motility to cough up the excess mucus. Excess mucus can also and fluid can also build up in the alveoli, causing patients to be highly susceptible to infections and can be presented as patchy consolidations in the lungs. Therefore, an increase of mucus buildup occurs which narrows the airway and triggers the productive cough with yellow phlegm that our patient is experiencing. The narrowing due to the obstruction disables air to efficiently flow to the alveoli, causing a wheezing sound that can be heard during auscultation. It leads to decreasing the amount of oxygen to enter for gas exchange, which also interferes with the flow of carbon dioxide that needs to be exhaled, causing air to be trapped within the alveolus, provoking the patient to experience dyspnea. Eventually, the numerous amount of air trapping that occurs within the alveolar level produce a hyperinflated lungs that is unable to exhale carbon dioxide out of the system. Due to the decreased concentration of oxygen to the alveoli and perfused with the lungs, induces the patient into hypoxemia, reducing the oxygen saturation. Carbon dioxide retention that is trapped within the alveoli increases the concentration of CO2 within the blood and causes the patient to be in a state of hypercapnia. Thus, a prolonged state of hypoxemia and hypercapnia will result in insufficient amount of oxygen being distributed to the peripheral tissues and initiate cyanosis to the oxygen-deprived tissues. The failure to undergo effective gas exchange increases the amount of bicarbonate in the blood, reducing the pH of the blood. The change in pH is then detected by the chemoreceptors located in the aortic and carotid bodies that signal the medulla to activate the sympathetic nervous system to increase the heart rate, that is tachycardia, and the respiratory rate, tachypnea. The initiative to increase the heart rate is to increase the cardiac output to distribute oxygenated blood to essential organs and tissues. Meanwhile, an increase in respiratory rate triggers the use of accessory muscles to increase the amount of oxygen to enter the lungs available for gas exchange. In conclusion, I hope this presentation gives an insight of COPD and its acute exacerbations, such as dyspnea, continuous cough, increased respiratory rate, and heart rate that can be experienced due to the exposure of irritants such as smoking, environmental pollutants, and give you some understanding of the pathogenesis that develops acute exacerbations of COPD. Thank you for listening to my presentation.